ده نكست واللي تحته ده بيرجع وده البوينتر على الشاشه
الشاشه
على السكرين.
هنا يطلع.
Thank you, Mr. Chairman, Dr. Mustafa Suleiman, and the organizing committee for the opportunity to participate. In the next presentation, I will give you a quick overview about cancer-associated thrombosis from evidence to practice. What's the risk of VTE in patients with cancer? It's actually quite high, reaching about 4 to 7 times that of non-cancer patients, with a high risk of recurrence as well. As you see here, about 2 to 3 times the risk of recurrence compared to non-cancer patients. And the risk also varies throughout the natural history of these patients. So if you look here, it's initially low, it rises with hospitalization, with chemotherapy and remission, it comes down, and then it rises again with the spread of disease and metastases. It also varies with the type of cancer, being very high with pancreas, brain, ovary, stomach cancer, and much less with bladder and breast cancer, as you see on this chart. It also varies with the stage of cancer. So if the cancer is in the early stage, the risk is quite low, and then it rises significantly as the patient goes on to the metastatic stage, regardless of the type of cancer that he has, as you see here. It also varies with the type of treatment that the patient gets. So with surgery, because of course of the long cancer surgery procedures and the hospitalization and so on, the risk initially goes up, and then it comes down if it is a curative surgery. Same thing with chemotherapy, it's initially high, and then with a remission, the risk goes down. So in summary, the risk factors for VTE patients for VTE in cancer patients can be grouped into patient-related factors, tumor-related factors, treatment-related factors, and there are also some biomarkers that will increase the risk for VTE. Now, the challenge or the problem with treating patients with cancer and VTE is that they are at an increased risk for both recurrent events as well as bleeding events compared to non-cancer patients. So they are a difficult group of patients to treat. You're running a tight balance. So what's the optimal treatment for these patients? Is it low molecular weight heparin? Is it DOACS? Is it warfarin? I think the studies have clearly shown superiority of low molecular weight heparin over vitamin K antagonists or warfarin. Several studies have shown that with no significant difference in bleeding. And this was shown by pivotal trials, the CLOT and the CATCH trials, which as you can see here, produces a significant drop in the events compared to vitamin K antagonists. Same data was shown in the phase 3 trials for DOACS, comparing DOACS to warfarin. As you see here, the Einstein trial for rivaroxaban, the Hokusai for edoxaban, Recover for the Bigatran, and Amplify for the apixaban. They all showed a drop in the recurrent events with cancer without a significant change in the bleeding events. And this was further confirmed with the real-world trials, the Zalia and the Zalia-Lia, again, significant drop of events without a significant increase in bleeding. So the next step was to compare DOACS with low molecular weight heparin directly, and this was initially done by the SELECT-D trial for rivaroxaban, showing a significant drop of the recurrent events with rivaroxaban compared to low molecular weight heparin, with a slightly increased risk of major bleeding compared to low molecular weight heparin. Exactly similar data was provided by the Hokusai trial for edoxaban, lower events but higher risk of bleeding. Then came the Caravaggio study for apixaban, again comparing that to low molecular weight heparin, and basically showed the same thing, significant reduction of 0.001p for recurrent events compared to low molecular weight heparin without any significant change in major bleeding. Some increase in non-major bleeding, but not in major bleeding. So apixaban seemed to have an advantage as far as bleeding is concerned. And when they broke that down to GI and non-GI bleeding, there was absolutely no difference between low molecular weight heparin and apixaban regarding bleeding events. Further data came from the ADAM trial, which compared again apixaban to low molecular weight heparin, showing the same results. drop of the recurrent events with no significant difference in bleeding. But the important finding here is that there was a significant difference as far as premature discontinuation with low molecular weight heparin versus apixaban because, of course, of the injection. Patients don't like to take injections for a very long time. So the compliance was much, much better with apixaban compared to low molecular weight heparin. What about the real-world trials? Again, it just confirmed what was found in the phase 3 trials, namely a drop of the recurrent events with a slight increase in bleeding compared to low molecular weight heparin. This the same thing. And furthermore, there was also a survival advantage of about 27% compared to low molecular weight heparin. Not exactly clear why that is. And so based on these trials and these data, the guidelines have also changed over time. And so if you look back in 2011, the ESMO Society here and then the ESMO in 2011 and the European Society in 2014, the ASCO in 2015, they all strongly recommended low molecular weight heparin over DOACS as the first line of treatment for cancer patients. And the ACCP in 2016 also stated the same thing. They stated clearly that low molecular weight heparin is preferable over both warfarin and DOACS for management of cancer patients. The American Society of Cardiology, ACC, in 2017, the same thing. Low molecular weight heparin is the #1 choice for cancer patients. But then things changed over time, and in 2020, the NICE guidelines came out and said for the first time that DOACS should be the preferable treatment over low molecular weight heparin for patients with VTE, and low molecular weight heparin or even warfarin should come as the second choice if for some reason the patient is not suitable for a DOAC therapy. And again, in 2021, the CHEST guidelines for VTE with cancer, they recommended the DOACS over low molecular weight heparin, and they said that even for luminal cancers, which are at a high risk of bleeding, you can use apixaban specifically because of its lower risk of bleeding compared to the other DOACs, just as well as low molecular weight heparin. Which takes us to the next question, which is which type of cancer should we give DOACS to? Generally, it's recommended to avoid DOACS in luminal cancers. That's GI cancer, GU cancer, any mucosal cancer. It's better to avoid DOACS because of the slightly increased risk of bleeding with these drugs. Apixaban can be an exception, as shown by the CHEST guidelines, because of its lower bleeding risk. Drug-drug interaction is another important question because some chemotherapeutic agents will potentiate the effect of DOACS and others will reduce the effect of DOACS. And so you have to keep in touch with your medical oncologist to make sure that you do not disturb the bleeding effect of the DOACS. The next question is, for how long should we keep these patients on DOACS? And I think most of the guidelines now recommend extended therapy for cancer patients because they are at continued risk for recurrence. So the general recommendation is as long as the cancer is active, as long as the patient is receiving chemotherapy, you should extend your cancer therapy. The final question that we have is, can we give DOACS for prevention in cancer patients, patients who do not have VTE but have cancer patients? The answer was given by the Cassini trial, which looked at high-risk patients and were given either a DOAC versus placebo. And the general recommendation, just for the sake of time, is that you should give these patients a prophylactic dose, even if they don't have VTE, if they are at high risk, and high risk meaning Corona score 2 or more. So to conclude, I think most of the trials have validated the role of DOACS in management of cancer patients. Be careful when prescribing it to mucosal malignancies, GI or GU malignancy. It's better to avoid DOACS in these situations. Maybe the apixaban is an exception because of its low bleeding rate. Beware of the potential drug-drug interaction. Check with your medical oncologist. And finally, as I mentioned, the guidelines generally recommend extended therapy for these patients as long as the cancer is still active. Thank you very much.